till now we have seen the management of the algorithms for unstable angina and NSTMI. We are going to the major area management of the acute STEMI myocardial infarction, segment elevation myocardial infarction. So let us see one by one. So what we have to do? First, history, physical, ECG monitoring, repeat drop test. If drop test is negative, you need to repeat. Suppose there is ST segment elevation already is there, then drop test is only redundant. So if you have ECG evidence of ST elevation, it is ST segment elevation. Drop is only a uh, sort of side-on investigation, but not the main investigation. If there is a doubtful ECG changes, ST elevations, then you do a drop. Then important thing is the patient eligible for lytic therapy? That's what you have to look for. What is the anatomical location of the infarct? And what are the complications associated? Anterior wall, inferior wall, posterior wall, lateral wall. Where is the infarct? Are there any associated complications like MR and heart failure? Always consider primary coronary intervention as the most important treatment for NSTEMI. For STEMI. NSTEMI we have already discussed. For ST segment elevation myocardial infarction, most important treatment is primary coronary intervention. Suppose the center does not have cath lab and doesn't have the facility for primary coronary intervention, then thrombolysis plus other treatment is the order. So what is the essence? History and physical suggestive of acute coronary event, ECG evidence of ST elevation, drop, do as a sort of add-on, eligibility for lysis criteria you look at the anatomical location, which particular area and which particular culprit vessel is usually involved, and whether there is any papillary muscle dysfunction or MR or heart failure. And first treatment you have to offer is primary coronary intervention. That is doing an angiogram and then trying to reperfuse and open up the vessel. If that facility is not available or the patient cannot be shifted in a reasonably good time like 4 or 5 hours to the center, then you have to thrombolyze and then transfer the patient. Okay. Now, symptoms onset, you have to take 5 minutes to EMS, emergency medical service. At the EMS, 10 minutes in the ER, and at the ER, 10 minutes for the history and physical, acquiring ECG, if necessary, drop, and STMI revascularization is the rule. Whether you physically use a thrombolytic agent and revascularize, or you go into the coronaries and then open up the coronaries, is the choice. But primary coronary intervention, if the procedure can be completed within 90 minutes, you opt for it. Otherwise, lysis you have to take up 30 minutes, you can complete the lysis. These are the various T changes we have seen. Normal T wave here, then hyperacute T wave, ST elevated T wave slowly becoming inverted, ST being pulled down. Finally, ST became normal and T inversion. And of course, the little Q wave remained, everything else disappeared. This is over a period of time, it changes. Now, normal Q waves, so normally septum is activated from left to right. There is a normal Q wave, and that produces a Q wave, which is a small negative deflection in the lead one. It is less than 4 millimeters in size. It is less than 0.04 seconds in the width. And now you go to the pathological Q wave. Suppose there is an infarction in the lateral wall here. Because the current is not going this side, all the current appears it is going to the right side. Then you have Q waves. These are called the pathological Q waves. Very deep Q waves, more than 25% of the subsequent R wave, more than 0.04 seconds, more than 4 millimeters is the size. These are the criteria. More than 25% of the succeeding R wave, or more than 4 millimeters, or more than 0.4 seconds, or one small box. Then that is a pathological Q wave. Where can be seen? They will be in the lead opposite to the lead of infarction. If the lead of infarction is lateral V5, V6, you see the Q waves in V1 and V2. So if you see the infarction is inferior, L2, L3, you see the Q waves in the opposite lead. Okay. Now, this is normal ECG, ST elevation, hyperacute, peak T waves, then ST elevation, T waves return to normal, then ST returning normal, T wave inversion beginning, and then Q waves are formed. They have become persistent Q waves, and ST has returned to normal. Q wave and T inversion are the only old signs. Coronary anatomy, we have seen right coronary artery and its right ventricular branch, sinus nodal branch, and then the anterior marginal branches and posterior diagonal arteries. When you go to the left side, left main trunk, this is left main disease is dangerous because it occludes both the circulations. So LCX is on one side and LAD on the other side. You have the septal branch here and also the left descending branches, first diagonal branch, second diagonal branch, like that. This is the LCX there, and there they go onto the lateral and the posterior surface. Anterior surface is perfused by LAD and left circumference, lateral surface by LCX, partly by LAD, inferior surface by RCA and LAD, posterior surface by RCA and LCX. Right and left coronary arteries arise from the aorta. They are small tubes of 25 millimeters, 2.5 millimeters at the origin, and at the terminal part they are only 0.5 millimeter in size. Coronary arteries, remember, they fill during the diastole. During systole, the heart contracts, so the coronaries are not open. Only during the diastole, the coronary is open. The filling occurs during the diastole. The flow is from the epicardium to the endocardium. Endocardium is in contact with the blood, but cannot draw one drop of blood from the endocardium. It has to come through the epicardial vessel. This is called poverty amidst plenty. So anterior, lateral, inferior, posterior. Anterior is this part of the heart. LAD is the culprit vessel. Lateral LAD or LCX. Inferior RCA. Posterior RCA plus LCX. What are the leads affected? V1, V2 and V2, V2, V3. V1, V2 septal. V3, V4 are the anterior. So lateral are V5, V6 and L1 AVL, inferior L2, L3 and AVF, and finally posterior V1, V2 leads will show mirror changes because posterior surface is not accessible directly. It is sitting in front of the esophagus, and that is the posterior surface. Okay. Now, tabular wise, these red areas are L1, AVL, V5, V6 is lateral, that is LCX. The blue one, V3, V4 are anterior, V1, V2 are septal, both are LAD. And then the purple color one, L2, L3, AVF changes are posterior diagonal arteries of the RCA or main RCA itself. AVR is the lead does not generally show any infarction changes. The TIMI scores you have to obtain age 65 to 75, 4 years, 2 points, more than 75, 3 points, DM, hypertension and angina, 1 point, systolic hypotension, 3 points, heart rate tachycardia more than 100, 2 points, HILIP class 2 and 3, 2 points, anterior STMI and LBB if it is there, it is 1 point, time to reperfusion is more than 4 hours, 1 point, very thin individual less than 67, again 1 point. This gives you the TIMI risk score. Now, DD of the ST segment elevation. You must always know this: pericarditis, aortic dissection, plus coronary involvement, prior MI with aneurysm, LVH or AS with LV strain, HOCM, Brugada syndrome, coronary vasospasm, early repolarization changes, pulmonary embolism, and hyperkalemia. This could be a short notes for you. DD of the ST segment elevation infarction. History and physical, look for exact time of onset, DDF, ST segment elevation, contraindications for lysis, signs of CHF and aortic dissection and other complications. Lab values, CBC, basic biochemistry, prothrombin time INR, cardiac biomarkers. What are biomarkers? HSCRP, TROP, and then anti-proBNP. Records, prior ECGs, last cath reports, previous CABG report, and echo report. So as you can see, if the BNP values are more, it indicates that the risk for mortality is very high, particularly patients with NSTEMI. Now you see the triple markers in the acute coronary syndrome. What are triple markers? Triple markers are elevated biomarkers plus also CRP and BNP. Drop I, CRP and the BNP together are called the triple markers. When all the three are involved, naturally the mortality is more. Now, we'll go to the next slide. What are the various anti-thrombotic agents I have got? Antiplatelets, anticoagulants, fibrinolytics. Antiplatelets prevent the formation of the clot. Anticoagulants prevent the formation of thrombus. Antiplatelet agents prevent the formation of plaque rupture, stabilize the plaque and stabilize the platelets, so much so no ongoing thrombosis will be possible. Anticoagulants will prevent further clotting. Fibrinolytic agents will dissolve the already formed clot. Roles are different. These are in the early stages to prevent thrombosis. These are to prevent further thrombosis. These are to lyse the thrombosis. Now, what are the various drugs we have got? There is one receptor, NO receptor, prostacyclin receptor, ADP receptor, thrombin receptor, thromboxane A2 receptor, and all these are attacked by different substances. And this final common pathway is the G2B3A activation. So we can either block in the final way by using the G2B3A blockers like epsiximab, tirofibon, or eptifibatide, or we can attack any one of the mechanisms. For example, dipyridamole, which we used to use as students left and right, is available as persantin. It affects the PDE. Cilostazol, which we use for peripheral arterial disease, it also affects the cyclic AMP to AMP. This is cyclic GMP to GMP is dipyridamole, AMP to cyclic AMP to AMP is cilostazol. G2B3A are the final common pathway. Now, aspirin acts on the cyclooxygenase enzyme. Arachidonic acid to thromboxane A2 is catalyzed by COX. COX is COX. That is the cyclooxygenase. Aspirin interferes here. Your clopidogrel interferes at the ADP receptors. What are the ADP receptors? P2Y, P2Y12. These are the P2Y12 is the are the receptors of the ADP blockers. Ticlopidine, clopidogrel are the agents which act here. Now, beroprost, epoprosterol, iloprost, they block the prostacyclins. All these finally lead to the same benefit only. Direct thrombin inhibitors and vitamin K antagonists like thrombin, etc., and heparins, they act on this site. So what are the agents? I have the prostacyclin inhibitors like beroprostendol. I have the ADP inhibitors like ticlopidine and clopidogrel. I have the antithrombins direct acting on the thrombin receptors like vitamin K antagonists, heparin and warfarin and other things are the direct thrombin inhibitors. I have thromboxane A2 blockers like my aspirin. I have also got the dipyridamole for the cyclic GMP. I have cilostazol for the cyclic AMP. And finally, all of them have to act through the, they have to make the fibrinogen into fibrin and form the clot. That step is blocked by epsiximab, tirofibon, and eptifibatide. This one drug summarizes the mechanism of action of various antiplatelet, thrombolytic agents. Of course, not fibrinolytic agents. Fibrinolytic agents come separately. Okay. Now, you see clopidogrel bisulfate and ticlopidine, they act on the ADP receptors. G2B3R, they act on the fibrinogen to fibrin conversion, that is the fibrinogen receptors. Aspirin acts on the COX enzyme. Thromboxane A2 formation is inhibited. Collagen thromboxane A2, they also activate the platelets. Phosphodiesterase inhibitors like dipyridamole act on the first this prevention of the activation of platelets. Okay, now there's probably some animation, that's why it's not going. Okay, so there are platelet receptors are there, I told you. Thrombin receptors, P receptors, C receptors, thromboxane A2, E receptors, ADP receptors, G2B, 3A blockers, all of them. And finally, for the fibrinogen to fibrin, that is the link between the firm link between the platelets. Two platelets to be bound together, we require the fibrin bridge, and this is where your G2B, 3A blockers. These are there. These go and block that particular area, and no fibrin network is formed. So now let's go to the aspirin and cardiovascular protection. Aspirin, acetylsalicylic acid, irreversibly activates cyclooxygen 1 and decreases the thromboxane 8. What is this irreversibly? The life of the platelet is around 5 to 8 days. So if you are using aspirin, the effect of the aspirin will be there on all the circulating platelets. New platelets, of course, will not be affected by the aspirin. That is why anybody going for any procedure, they ask to stop the aspirin for 4 days. Because 50-60% of the platelets are old platelets. Anyway, they are going to die in another 3 or 4 days. So 4 days is a reasonable time to withhold the antiplatelet agent aspirin before any procedure is there. So new platelets to form 8 to 10 days. So that's why at least 4 days you elapse between starting any surgery and use of aspirin. GA bleed occurs 1 in 670 patient years. What is patient years? One patient taking for 1 year is one patient year. 670 patient year means 670 patients taking for 1 year, or 67 patients taking for 10 years. Means GA bleeding is very rare. Don't be afraid of aspirin GA bleeding. If it comes, of course, we will tackle and replace with clopidogrel. Secondary, when do I give aspirin? Every CV disease case, aspirin must be there. Dose only differs, 75, 120, 150 or 325, depending on the necessity. Primary prevention is required. Primary means there is no heart disease and there is no established coronary vascular disease, but risk factors are there. When do I give? More than 2 risk factors, or if the patient is a diabetic. So, aspirin secondary prevention, irrespective of diabetes and number of risk factors, everybody who had got a vascular event must get aspirin. Okay, primary prevention, no vascular event has occurred, patient has 2 risk factors or diabetes, you must prescribe aspirin. You will be doing a world of good by prescribing aspirin. In acute coronary syndrome, the dose is 325, non-entry coated. Entry coated is 75, 150 available. You can powder it and give it. Always one for maintenance, always 75 milligrams to 150 milligrams is preferable. Aspirin intolerant patients, clopidogrel 75 milligrams should be given. Remember, there is a phenomenon called aspirin resistance. In 15% of the acute myocardial infarctions, aspirin will not work because they are resistant to aspirin. Just like antibiotic resistance, aspirin resistance. That means the desired antiplatelet effect will not be seen. Now, ADP receptor blockage, we know, is by clopidogrel, ticlopidin, prasugrel. And how does it act? There is a receptor there. This particular drug goes and blocks that receptor, and it is reversible. Canaglor, AZG, these are reversible, whereas irreversibly, clopidogrel, ticlopidin, prasugrel. And then what will happen? The GI protein is there, and then calcium channels, calcium ions are released. We know that for every part of the coagulation process we require, including the platelet activation. Suppose I give clopidogrel, it blocks the release of the calcium, so much so platelets are not activated, no adhesion, no activation, no aggregation. That is the how. If you must know how it acts. Clopidogrel is an ADP P2Y12 receptor blocker. It blocks the receptor. GI protein converting into cyclic GI into GMP, it releases calcium. That calcium will not be available when you block this. In the absence of calcium, platelet activation is not there. Clopidogrel, prasugrel, or ADP inhibitor receptor blockers. Ticlopidine is not used because it decreases the hepatic function and also decreases the platelets. Better give clopidogrel or prasugrel. Side effects of clopidogrel are very few. If at all you get a side effect, neutropenia you will see. Those how much? Stat dose is 300 with 325 aspirin, and then 75 milligrams is the continuation dose, combined with or without ASA depending on the need. How long? Minimum of 1 month for ACS, usually up to 1 year. Indicated when? All cases of unstable angina, NSTMI, and STMI. Prasugrel is more efficacious than clopidogrel. What is the dose of prasugrel? 60 milligrams stat and 10 milligrams daily. So if a patient is a high risk patient, you can now give prasugrel 60 mg stat dose and maintain with 10 milligram. If prasugrel is not available, or if you want a cheaper drug, 300 milligrams of clopidogrel now available, 300 tablet itself. Earlier days we used to give 4 tablets of 75. Now 300 mg tablet is available. Maintenance dose is 75 milligrams. Dipyridamole was used when we were students 40-50 years back. Now dipyridamole is not used in acute coronary syndrome. 3 drugs are known as G2B3A receptor inhibitors. What is this G2B3A? G2B3A proteins are required for conversion of fibrinogen into fibrin. If that step is blocked, there is no fibrin, so there is no cell adhesion taking place. What are the 3 drugs? Epciximab, tirofiban, eptifibatide. All are IV route. They block the final pathway of conversion of fibrinogen to fibrin. They prevent the platelet aggregation by blocking the fibrin links. In high-risk ESCS patients and in patients with PCI, outcome benefit is beyond the combination of ASA, clopidogrel, and low molecular heparin. So how many drugs? ASA, clopidogrel, unfractionated heparin, or low molecular heparin. On top of that, people whose TIMI risk score is high, people who are diabetics, people who are going to be taken to the cath lab for PCI, they must receive one of the 3 drugs, G2B3A receptor blocker. Medium and high risk ESCS should be added to aspirin, low molecular weight, and clopidogrel early, all before the angiography and the PCA. Low risk patients, you don't have to give 2B3A blockers. Aspirin, clopidogrel itself is sufficient. Okay. Pivaluridine replaces the heparin. If you are giving heparin, then you can use pivaluridine plus G2B3A blockers. STEMI treatment with fibrinolysis, if you are giving, don't use 2B3A blockers. If you are using PCI, you must give. If you are not using PCI, no cath lab is available. You are using a fibrinolytic agent. Don't use 2B3A receptors because of the increased bleeding risk. Now you must understand the role of G2B receptors, 2B3A blockers. What are these? What are these? G2B3A receptors are required for the conversion of fibrinogen to fibrin. These 3 drugs, any one of them, abiciximab, terifibon, or eptifibatide, they block the 2B3A channel, the final channel. So much so, fibrin to fibrinogen to fibrin is formed. Now, when do I use them? I must use them in all patients of high risk ESCS, STMI elevation, myocardial infarction, TIMI risk score is high, patient is diabetic, elderly, reinfarction, and all these conditions. And also, when I am going to do the procedure in the cath lab, I must give one of these drugs along with aspirin, clopidogrel, and unfractionated heparin. In medium risk to high risk cases, they can be added to aspirin, LMW, heparin, and clopidogrel, all before the angiography. Low risk patients, ASA and clopidogrel are sufficient and not G3 2B3A blockers. Bivalirudin can replace the heparin along with G2B3A you can use. Another important point is if you are not going to take up the patient for fibrinogen for PCI into the cath lab, or if such facility is not available, or if the patient cannot afford PCI and procedure might cost 3 or 4 lakhs, then you have to do fibrinolysis. At that time, you should withhold G3 2B3A receptor blockers. Okay. Now, coagulation cascade, the extrinsic pathway, the intrinsic pathway. The final common pathway is factor 10A. 10A acts on the prothrombin factor 2 to thrombin. Thrombin acts on the fibrinogen to fibrin, and then the clot will form. Now, here prothrombin to thrombin we require factor 5, calcium, phospholipid, and factor 10A all together can convert the prothrombin to thrombin. How is factor 10A formed? By the activation of 12A, then HMWK, prokallikrein, and then the factor 9 and 11, and then factor 9A to the 8-7A complex will form. This is the intrinsic pathway. Extrinsic pathway, injury to the tissue factor 8-7A plus tissue factor and calcium, shorter. This is intrinsic pathway, is longer. We have already seen this earlier. Now, what are the anticoagulants that are available? Heparin, low molecular weight, fondaparinux, bivalirudin. Now, this is the activators bind here. This is the antithrombin and the thrombin. Thrombin acts on the fibrinogen to form the fibrinogen to fibrin. Thrombin and fibrinogen like a lock and key fit will be there. So bivalirudin and others like agatroban, dabigatran, they act here and prevent the action of thrombin on the fibrinogen. Okay. Extrinsic pathway, intrinsic pathway. Both lead to 10A formation. This is the crossroad. Fondaparinux directly acts on 10A. Okay, heparin acts on the intrinsic pathway, and then you have got the low molecular weight directly act on the 10A, and also heparin acts on the 10A also directly. And heparin acts here also. What are the various areas? Mildly on the intrinsic pathway, blocks the 10A and also blocks the thrombin to fibrinogen conversion here also. All the three places heparin acts. Low molecular heparin acts on 10 and partly on the thrombin. Whereas my bivalirudin, argatroban or dabigatran, they act here. This summarizes the mechanism of action of various anticoagulants and their site of action. Low molecular heparin. Advantages for conventional heparin: better bioavailability, higher ratio of 3:1 anti-10A effect, and longer anti-10A activity, devoid of rebound effect, no induces less platelet activation. There is no need to monitor these things. Ease of use, they are available for subcutaneous use either once a day or twice a day. You don't have to monitor the prothrombin time or any other clotting parameters. And another thing is these drugs are available parenterally, QD or BID, they can be used. Now, which anticoagulant I choose? Unfractionated heparin, low molecular heparin, fondaparin, and then the bivalirudin. Severe CKD is there, use caution here. Avoid LMW, avoid fondaparinux, and then biliverdin with caution. So UHF and biliverdin can be given with caution. LMWH and fondaparinux should not be given in a patient of severe CKD. There is increased bleeding. This is neutral here, very selective and very good and very good. There is increased risk of bleeding. Better give fondaparinux or bivalirudin. There is already thrombocytopenia. heparin-induced thrombocytopenia. HIT is heparin-induced thrombocytopenia. Don't use heparin. If there is thrombocytopenia, better you give LMWH or Fondaparinux. Best is bivalirudin. Early invasive treatment, these are very good. Avoid Fondaparinux, and biliverdin also is very good. This summarizes what anticoagulant should I use. Severe CKD, UHF and bivalirudin. Increased risk of bleeding, Fondaparinux and bivalirudin. And thrombocytopenia, best is bivalirudin, or you use LMWH or Fondaparinux. Early invasive treatment is contemplated, except Fondaparinux, all are good. Okay. Now, antithrombotic agents in acute coronary syndrome. Condition, antiplatelet, anticoagulant, fibrinolytic. Low risk or conservative management, no fibrinolytics. Only aspirin and clopidogrel you give, 325 plus 300, follow with 75 plus 75. Anticoagulants, unfractionated heparin, low molecular heparin, Fondaparinux, and bivalirudin. Any one of these things. Fibrinolytics not required. High risk NSTMI, invasive treatment is planned. ASA, clopidogrel, G2B3A blockers, because invasive treatment is planned. Use unfractionated heparin, bivalirudin, and then no fibrinolysis. Please never fibrinolyze NSTMI patient, because the risk of bleed is very high. Suppose there is STMI and PCI is not available in that center, there is no way you can go to the cath lab immediately, then use ASA, clopidogrel, unfractionated heparin or Fondaparinux, and then you have to give fibrinolytic. What is the fibrinolytic? Teneliglipase, RTPA, RTPA, TNK, RTPA, RTPA. Streptokaisinase is rarely used nowadays. Okay. Now, so antithrombotic agents, when you are considering PCI, primary PCI, aspirin, clopidogrel, G2B3A blocker, plus unfractionated heparin, all these are antiplatelets. This is the anticoagulant, fibrinolysis none, because you are taking up in the cath lab. Elective or low risk PCI, aspirin, clopidogrel, no abciximab, unfractionated heparin or bivalirudin, and then no fibrinolytic. Elective high risk patients, aspirin, clopidogrel, abciximab, or eptifibatide, unfractionated heparin or bivalirudin, and no fibrinolytics. Means every condition, whenever you are going to take a PCI, either low risk or high risk or primary, no fibrinolytics. NSTMI, no fibrinolytics. When I do fibrinolysis, ST segment elevation, where I have no opportunity to do a primary PCI, I must do the fibrinolysis. With what? TNK, RTPA, or TPA. Okay. Now, criteria for reperfusion. Typical ischemic chest pain lasting more than 20 minutes, onset within previous 6 to 12 hours. There is no point in giving the reperfusion after 12 hours. Studies have shown the clot is already organized and formed, and it will not be able to open up the vessel after 12 hours. If the 1 millimeter ST elevation in 2 or more limb leads there, or 2 millimeter ST elevation in 2 or more chest leads, new onset bundle, branch block, you must reperfuse. What are the people whom I reperfuse? Chest pain more than 20 minutes, onset within 6 hours preferably, not more than 12 hours. ST elevation in the limb leads, 2 or more leads, contiguous leads in 1 millimeter, or 2 millimeter ST elevation and 2 or more chest leads. New onset bundle branch block. These are the criteria for reperfusion. Reperfusion in the absence of contraindications. How do I do that? Primary PCI, where facility available. Reperfusion is opening the vessel, and you can do it by angiographic procedure, or you can give a blind procedure like the thrombolytic therapy, depending on the availability, depending on the cost, depending on the patient's preference. Okay. Now, SK, TPA, RTPA, or TNK. So SK binds to the active sites. What is this? There's protein C. Protein C plasminogen inhibitors. Protein C inhibits plasminogen inhibitors. These inhibit the plasminogen and and then plasmin will be formed. Normally, what will happen? Plasminogen to plasmin. This is the procedure. For plasmin to plasminogen, this is activated by RTPA, RTPA, or streptokinase. So much so, more of the plasminogen is converted into plasmin. Plasminogen is a blunt scissor. Now all the caps are open, scissors are made ready. Plasmin is the scissor which cuts the clot. How does it act? The fibrinolytic agents, by cutting the clot. To cut the clot, what I need? I require the scissor called plasmin. How is it manufactured? From plasminogen. Which are the drugs which increase the conversion of plasminogen to plasmin? Streptokinase, TPA, RTPA, TNK, any one of them. Now, there are certain plasminogen inhibitors are there in the blood, particularly PAI1, plasminogen activator inhibitor. There is one substance. This plasminogen activator inhibitor, it increases the inhibition of plasminogen to plasmin. In myocardial infarction, PAI values will become very much more. Because the PAI is more, plasminogen is not converted into plasmin. There is no clot lysis. What you do? To overcome the PAI inhibition, you use either one of these three drugs and to block this action, allow the plasminogen to become plasmin, which facilitates the clot lysis. Now, first generation, second generation, third generation. Streptokinase, urokinase are the first generations. The problem is antibody formation. You cannot reuse it. Repeat the use. Whereas second generation, TPA or TPA. Third generation, RPA and then TNK TPA. And nowadays, better to use TNK and third generation. The advantage with the latest ones, third generation ones, are you don't have to give an infusion. They're a bolus dose. Just always keep 1 or 2 syringes of TNK or TPA in your cupboard. The moment you diagnose acute infarction, ST segment infarction, there is no availability of PCA facility, or patient is not willing or doesn't have the finances, give one bolus injection of the third generation. After giving that, you can electively do the PCA after transferring the patient after 12 hours also. This is how you work. Okay. Now, fibrinolytic agent and the choice. You have to comparative table. You require streptokinase, TPA, altipase, RTPA, retiplase, and tenecteplase. TNK is a tenecteplase. Okay, streptokinase, first one, fibrin selective, no. TPA is fibrin selective, RTPA fibrin selective, TNK tenecteplase is also fibrin selective. Duration 60 minutes, 90 minutes infusion, 10 minutes to repeat after 10 minutes. TNK 5 to 10 seconds just to give a bolus. That's the advantage. Half-life 23 hours, less than 5 hours, 13 to 16, more than 20 hours. Dosage 1.5 million units in NS. Here 15, 50 and 35 milligrams in that increments. RTPA 10 units plus 10 units. Here TNK 0.5 milligrams per kilogram stat in one bolus. And BP fall allergy you have to note, particularly with streptokinase. Whereas with the modern agents, there is no point of hypotension, there is no allergy. TIMI flow or reflow 3, 32% with the streptokinase, 45 to 54% with TPA, altipase, and then RTPA, retiplase 60%, and TNK 60%. Major bleeds, around 5% for everything, more so with SK. 30-day mortality, 7.4% with SK, 6.3, 6.2, 6.2. Slight mortality benefit for the newer agents. Cost 4,000, 30,000, 20,000, 18 to 20. Today, TNK injections are available for 15 to 18,000. Can buy and keep the injection as a reserve. A patient who is who requires fibrinolysis immediately give an injection of TNK 10 electropase. Now, time to reperfusion versus degree of benefit. Time is muscle. So you see, within 1 hour, 2 hours, 4 hours, 6 hours, 8 hours. Benefit in myocardial mortality reduction. After 6 hours, you see there is no benefit at all. Very little benefit until 8 hours. After that, no. First 1 to 2 hours, maximum benefit. The earliest you do, from pain time to reperfusion, mortality reduction in percentage, from 100%, the mortality reduction will be very good if you do it within first 2 hours. The time to reperfusion versus degree of benefit, time is muscle. Now, contraindications to thrombolysis. When I should not thrombolyze. Of course, one indication is NSTMI, you are unstable angina, you are not supposed to do thrombolysis. If the patient has got STMI, then also certain contraindications are there. Absolute, relative. Absolute means should never do. Relative, you can try with caution. Hemorrhagic CVA, already had a hemorrhagic stroke, cerebral hemorrhage, or hemorrhagic CVA history, or CI within critical limb ischemia within 3 months, intracranial aneurysms, arteriovenous malformations, intracranial tumors, closed head injury before 3 months, aortic dissection, severe hypertension, BP more than 180, 110, active bleed and bleeding diathesis, and then acute pericarditis. You should avoid thrombolysis because the risk of bleeding is relative. Prior CI 3 months ago, allergy or previous use of SK, recent internal bleed, prolonged CPR and trauma, major surgery within the past 3 weeks, active peptic ulcer disease, vascular punctures are available, and then severe menstrual bleed, history of ocular bleed, and pregnancy are relative contraindications. This is very important question. When do you do thrombolysis? What are the agents available? What are the various doses? Which is the preferred route and dose? And what are the indications and contraindications, absolute and relative? Okay, fatality of NSTMI. Now, 20% of myocardial infarctions are silent. Means they will not come with pain, diabetic neuropathy, autonomic neuropathy, elderly patients. 15 to 20% of the STMI die before admission. Lucky few. 10% die during hospitalization. Majority of the hospital deaths with the first 2 days. You have to, patient will ask, patient's attendant. We can't say anything for 48 hours, we have to say. Because major deaths will occur in the first 2 days. Emphasize the need for early intervention. Most deaths in the first year occur in the first 2 weeks of infarction. CHF, arrhythmias or aneurysms, they increase the fatality. Reperfusion within 2 hours, death is reduced to 50%. Now, 20% of the people don't present with pain. 15 to 20% they die before admission. 10% die in the hospital. Of that, within the first 2 days, maximum mortality. Emphasize the need for early intervention. And deaths in the first year are mostly in the first 2 weeks. Congestive heart failure, arrhythmias, and aneurysms are bad prognostic signs for fatality. And perfusion within 2 hours, death is reduced by 50%. Now, major acute coronary events. Major acute cardiac events. MACE, sudden cardiac death, SCD, acute myocardial infarction, unstable angina. Rupture of the high-risk or vulnerable plaques. Inner plaque material is exposed to the blood and irritates the formation of platelet fibrin thrombus. On the rupture may seal without detectable sequelae, or the patient may experience acute syndrome or sudden cardiac death. Majority of the vulnerable plaques appear insignificant on the CAG before rupture. That's what I showed you earlier. Less than 75% stenosis only will produce more myocardial infarction. So it's not the degree of stenosis, but the vulnerability of the plaque that is more important. Now, diagnostic factors for CAD. LV functional damage, severity of the CAD, modifiable factors. history of prior MI, ECG pathological Q waves, LV functional damage is there, CHF, cardiomegaly, in chest X-ray, ejection fraction less than 40 or unsystolic volume is lower, LV, RWA, regional wall motion abnormalities are there, and the echo conduction disturbances are there, mitral regurgitation is there, decreased exercise tolerance, all signify functional LV damage. Severity, anatomical severity, single vessel disease, double vessel disease, triple vessel disease, more severe. Degree of stenosis, extent of the stenosis. Transient IHD on Holter, ETT reduces ST deviations, exercise stress testing. And then progressive symptoms of ischemic heart disease, increasing age. These call for severity of the disease. Modifiable, diabetes, hypertension, dyslipidemia, obesity, smoking, other comorbidities, metabolic factors, ventricular arrhythmias, all are bad factors, risk factors which can be modified. RV infarction, that is right ventricular infarction. So there is STMI with the RV infarction is a high risk subset. Mortality is higher, up to 30%. Aggressive treatment with reperfusion is a must whenever you see RV infarction. In all cases, inferior wall myocardial infarction. Whenever you see inferior wall infarction, you must also look for RV infarction because the same blood vessel, RCX, supplies the RCA supplies the inferior wall as well as the right ventricle. ECG recording and right-sided precordial leads V2R, V3R, V4R, V5R, V6R must be done. ST elevation in V4R is a poor predictor for prognosis. Low cardiac output in inferior wall myocardial infarction is the key for the right ventricular myocardial infarction. So, whenever you see an inferior wall myocardial infarction, look for the right ventricular infarction. Together, they have poor prognosis. Treatment objectives: maintain the RV preload, give inotropic support like dopamine, decrease the afterload of the RV like using diuretics, early reperfusion by PCA, PCI, CABG or thrombolysis. IV normal saline, no diuretics, nitrates, give ACI, intra-arterial balloon pump inhibitors. So normally, in case of RV infarction, generally we don't use the diuretics. We use normal saline and then nitrates and then ACE inhibitors, intra-aortic balloon pumping. Now, pathways and triage and transfer for PCI in STMI. STMI, I told you, the primary treatment is try and reperfuse open up the vessel and do in the cath lab. This is called primary coronary intervention. So when you want to do the primary coronary intervention, what is the algorithm you are having? What's the algorithm you are having? Now, STMI patient who is a candidate for reperfusion. Okay, initially seen at the PCI capability facility like Manipal Hospital. Sent to cath lab for primary PCI class 1 indication. Okay. Prepare antithrombotics, anticoagulant plus antipyretic, diagnostic angiography. The answers can be medical therapy, PCI, CABG. CAB is there, then electively you have to take up the CAB. PCI, open up the vessel, do either stenting, drug-eluted or no stenting, or simply do the angioplasty. And there is no severe obstruction and critical obstruction, then you do the medical treatment. Supposing you have this, transfer for primary PCI. So cath lab facility is there, then you transfer for the primary PCI. Now, initially seen at the non-PCI capability center like a primary health center, there is no PCI capability. Then initial treatment with fibrinolytic therapy must be given. But fibrinolytic, tenecteplase or atiplase or any one of those agents which we have thought of. Now, is the patient is high risk or no risk? No high risk. Transfer to PCI facility may be considered, especially if the speak symptoms persist and failure to reperfuse is suspected. High-risk patient transfer to PCI facility is reasonable for early diagnostic angio and possible PCI or CABG. High-risk patient is defined by 2007 STEMI-focused update undergo cath lab. Now, what we do here? At PCI facility, evaluate for timing. If the timing is within 6 to 12 hours, then you can go for the angioplasty. Diagnostic angio, and depending on that, you do medical treatment or PCI or CABC. Now, problem. Salvage problem. What are the salvage problems? Patients delay, time between the onset of symptoms and emergency call. How do I overcome that? Educate the patient. What do I do? Any chest pain, don't dub it as gas trouble. Take 325 milligrams of aspirin. Immediately call for the ambulance. This education must be given. Number two, transport delay. Time between emergency call, patient has called, patient is contacted, and time delay in paramedics and organizations have to work. In certain countries which choke traffics, they are transporting these by helicopters from the home. They take them by the small helicopters, so 2-3 people can sit down. And I don't know when India will get such facility from remote areas to bring patients. Treatment delay, door to needle, first medical contact to needle, door to balloon, first medical contact to balloon. We here have to organize the hospital workflow in such a way this delay can be cut. So we can avoid patients' delay by education, transportation delay by organizational network and then the logistics, and time delay after coming to the hospital by following very crisp protocols. Now, management of ACS depending upon this is a very, very useful summary slide. Stable angina, aspirin and beta blocker, no low molecular heparin or heparin, no ICU care, no thrombolysis, no primary PTC. Unstable angina, aspirin, clopidogrel, and beta blocker. A and B, aspirin, B beta blocker, C clopidogrel. 3 drugs are there. Beta blocker A and C, 2 platelet agents and beta blocker. And you have to add unfractionated heparin or low molecular heparin. Then ICU care, yes or no, depending on the response. Repeat the drop after 6 hours. Symptoms subside. Drop is negative. You can send him. No thrombolysis, no primary PCA. If it is NSTIMI, A aspirin, B beta blocker, C clopidogrel, G2B, 2A, 2B3A inhibitor should also be added. Unfractionated heparin, low molecular heparin should be given. ICU care is a must for NSTMI. We should not lyse the patient. Primary PTCA you can attempt as early as possible. STMI with acute myocardial infarction, A aspirin, B beta blocker, C clopidogrel, G2B3B, 3A, G2BA, 2B3A inhibitor, unfractionated heparin must be given. ICU care essential. Lysis if primary PCA is not possible. If you can do primary PCA, do the primary PCA. This one table summarizes the treatment from stable angina, unstable angina, NSTMI, and STMI. Okay. What are the post-CABG discharge advice? What do I write and send the patient? Aspirin, atorvastatin, ACE inhibitor, A1C control, beta blockers. 4 years plus B. B is beta blocker. These are the drugs. Lifestyle, no smoking, slowly increase physical activity, medical nutrition therapy, cardiac rehabilitation, periodic follow-up. This is very important. What you prescribe? How much aspirin? 75 to 150. Atorvastatin, minimum of 20 milligrams of rosuvastatin, maybe 40 milligrams of rosuvastatin. If you are using atorvastatin, 80 milligrams of atorvastatin or 40 milligrams minimum you have to use. ACE inhibitors, ramipril, perindopril are preferred agents. A1C control, preferably with insulin or other modern drugs. Beta blocker, carvedilol, metoprolol, bisoprolol, any one of the newer beta blockers. Lifestyle, smoking stopping, physical activity, medical nutrition, cardiac rehabilitation, and follow-up. Now, what are the complications of acute MI? This could be a short note. Very easily you can remember by using acute MI. It can lead to heart failure, that is lungs fluid in the lungs, or it can lead to mural thrombus and that can get dislodged. RV infarct from LV it can extend to RV. Prognosis is poor. And then pericarditis can develop. Arrhythmias can develop. Extension of the ischemia from initial small area to larger area. Expansion of the aneurysm. And finally, mechanical rupture of the papillary muscle or the interventricular septum. What are all the things? Arrhythmia, pericarditis, RV infarct, mural thrombus, heart failure, mechanical rupture, expansion of the aneurysm, extension of the ischemia, and arrhythmia. All these can occur in acute myocardial infarction as complications. Now, complications after EMI. Recurrent chest pain, post-infarction angina, ongoing ischemia, acute pericarditis, Dresser's syndrome, arrhythmias like, transcardiac and transventricular pacing, ICDS, we have to use the arrhythmia should be tackled by this patient. And then cardiogenic shock, mechanical complications like aneurysm, pseudoaneurysms, free wall rupture, papillary muscle rupture, ventricular septal rupture. Treatment related to the complications, beware of the bleed and heparin-induced thrombocytopenia. Now, cardiogenic shock. Evidence of hypoperfusion, oliguria, cold clammy skin, especially hands and feet, impaired mentation, systolic blood pressure less than 90, LV and diastolic pressure is more than 18, evidence of primary cardiac abnormality like STMI, cardiac index is less than 1.8 per liter per meter square. Intra-aortic balloon pump and full inotropic support is required. Prognosis for cardiogenic shock is rather poor. Now, this we have completed the STMI management and we have got the ACS ECGs. Probably we will quickly go through those things one by one because you have seen them in the ECG class. You see there is a initial this one. This is the T inversions are there and ST elevation and T inversions in the anterior leads. Anterior infarction. Unstable angina, not yet infarction because we don't have typical ST elevation, only T wave changes and some ST changes are there, a case of unstable angina. And in this, you do a drop, repeat the drop, it may progress on to STMI or NSTMI. Now, this is vasospastic angina or fringe metal angina, where very severe ST elevations are seen. And this is only vasospasm and not occlusion. And it is transient. And ECG after 45 minutes or 1 hour will become normal. Okay. Now you see, this is about the NSTMI because non-ST segment elevation instead ST depressions on the lateral and the lateral wall leads V5, V6 and L1, L2. T inversions are not still there. This is NSTMI. How to manage that? We have seen the algorithm. Now you see here STMI. This is a typical ST elevation myocardial infarction. Same person after treatment of 3 weeks. You see the Q waves, STs have returned to normal. Then you have got the critical narrowing of the LAD. When there is critical narrowing of LAD, you see the elevation, ST elevations there, typical in all the anterior leads here. And now you see acute inferior wall, anterior wall infarction means L1, V2, V3, V4. These are the areas for the anterior infarction. L1, V2, V3, particularly V1, V2, V3, V4. V1, V2 are septal leads, V3, V4 are the anterior leads. Now you see here, this is a hyperacute MI. You see very sharp elevation of the ST segment along with peak T waves there. This is a very hyperacute MI. Then you see here acute septal infarction. V1, V2, V3 are affected. No other leads are affected. Septal leads only are affected. Now, acute lateral infarct. This is the LAD territory. Anterolateral infarct, lateral means L1, AVL, V5, V6. These are the four leads which show Q wave and then the ST changes and T inversions you will see. Now you see acute anterolateral MI. Anterolateral, that means V1, V2, V3, V4, V5, V6, all are affected. And this is an anterolateral. Anterolateral usually is the left main disease or LAD disease will be there. Then you have got acute anterolateral MI. Same thing. ST elevations are very profound in the anterolateral leads. Now, you have got what is called the angiographic stenosis you have demonstrated, and that is the reason for this ST segment changes. And we have thrombolized, and then the vessels will get opened up, then the ST segments will return to baseline. Now you have got stable anterolateral MI. So we have treated the patient, only T inversions are there. We don't see any other evidence of infarction. It is a stable anterolateral and new onset LBB. If you see the left bundle branch, M pattern in L1 and AVL and V5, V6 also. M pattern is there, or slurred QRS complexes. Primary T inversions, you see, and the T wave is in the same direction as the QRS. That means you should suspect LBB with infarction. Now, inferior wall infarction or diaphragmatic surface infarction. V2, L2, L3 and AV for the leads, and may in the complementary changes in V5, V6. QS pattern may be there, and a small Q in the V5, V6 can be seen. Then you have got the acute inferior wall infarction. Here also L2, L3, AVF are involved, complementary changes in L1 and AV. Now you have got this acute inferior posterior. So we have the inferior wall here, and V1 R by S ratio is more than 1. That is a mirror change there, inferior posterior infarction. Then inferior infarction, thrombolysis, same inferior infarct below. We did the thrombolysis, the ST segment changes disappeared. Now, you have got the old inferior infarct. We only see QS complexes. Nothing else is there in the ECG. Now, posterior infarct, a true posterior infarct. That means RCA territory is affected. V1 is the lead which will show there will be mirror changes. This tall R wave is the Q wave. This ST depression is the ST elevation. This T is the inverted T actually. These are the mirror changes that are there. Now you have got acute posterior infarction. You can see R by S ratio. The ST depressions or ST elevations in the mirror changes are there. And then you have got inferior and posterior. This is the inferior lead and this is the posterior. So both combined you have got. And you can take right-sided chest leads also. You have to see whenever you see inferior infarct, you must look for the right-sided leads also, because RV infarction may be associated. Old inferior posterior, all changes have settled. Only the Q waves are remaining. Now you have got MI in dextrocardia. Heart is on the right side. So naturally, we don't see much of changes in the V5, V6. If you put the right-sided leads, then you can see the thing. Note ECG carefully. It's an eye opener. 55-year-old patient is seen by another doctor and sent to me. She has dextrocardia, of which she is unaware. She has typical clinical features of MI. Routine chest leads placed on the left side showed no evidence of MI. But once we have put it on the right side, ECG with right-sided chest leads, V2R to V6 are typical antireceptor infarct is observed in this particular lady. Always, when the symptoms are not correlating, take right-sided leads and look for dextrocardia or right ventricular infarction. Dextrocardia and MI, this also we have seen. Now what we have seen, right ventricular MI. You see here also, you can see left-sided leads are showing depression and inferior leads or right-sided leads, L2, L3, AVF are showing ST elevation, and V4 or V5 are showing the ST elevation because of the right ventricular infarction. And now the primary prevention is the key. What is the primary prevention we do? Avoid risk factor strategies. Key points to remember: risk for CAD begins early, plaque buildup develops later in the life. CAD is not an unavoidable consequence of all. Risky blood paves way for plaque buildup. Small, soft, inflamed, lipid-rich plaques are there. 75% of the MI occur in people with less than 25% stenosis. One-third have advanced warning signs. Half of the sudden cardiac deaths occur in the healthy persons. Two-thirds of the sudden cardiac occur before they reach the hospital. Don't wait. Begin heart-healthy lifestyle right now. How important is CAG? Two-thirds of the ACS results in the coronary artery stenosis, and then you have more than 50% stenosis. We know we don't see in many patients, but we see mostly less than 50%. CAG may give false sensitive sense of security. Asymptomatic subject CAG is not indicated. Instead, focus on the conventional and novel risk factors. And ACS and CAG is a must to plan for a treatment strategy. In ACS, you must do coronary angiogram to plan medical and angioplasty, stent, or CABG. Nature of plaque determines the occlusion. Lipid-rich, soft plaques ruptures are called the vulnerable plaques. The deadliest devil, the smoking. He is not smoking and enjoying the cigarette. Cigarette is in fact smoking him. This is very important for us. The 7 steps are Saptapadi: screen, define and target high-risk patient, modify lifestyle, medical nutrition therapy, and then physical activity, explain and persuade to quit smoking, alcohol, aspirin, in all those with more than one risk factors, aggressive control of diabetes to less than 7, attain BP goal, diabetes 10 millimeters lesser you keep, AC inhibitor, statin for all diabetics, statin for all those with the LDL increase. Address all the risk factors. The 6 components: MND, physical activity, smoking, alcohol, stress reduction, metabolic syndrome, and CV risk evaluation. This is called the total lifestyle control. Genetics loads the gun, environment pulls the trigger. Even if you have a loaded gun, if you can avoid the risk factors, there is no harm. NAS, Director CADI Research. Just being an Indian places you at a higher risk of heart disease than having high cholesterol and being smoker. A lot of people, they say they look healthy, feel healthy, they don't get tested for heart disease. By the time some of them find out they have CAD, they're either in an ambulance or in a hospital bed or they are no more. Take care of National Asian Indian Heart Disease Program from All India Institute of Medical Science in New Delhi. CAD is a tsunami. CAD in India, immediate steps of awareness are required. Among doctors is crucial. Need to educate the people. Second step is employing preventive strategies. And key to tackling the tsunami lays in prevention. Who told? Padma Shri Ashok Sheth. He holds Guinness Book of World Record for the number of procedures he has done on the coronaries. That person is telling prevention is the only way. This is what you have to understand. Now, 2.5 million years it has taken for the ape man to become an erect, healthy man. Now what happened? In 50 years, we crashed all that, converted that fellow into a McDonald man, Burger King man, Zomato man, Swiggy man, cardiometabolic man. Now, dear God, let a miracle happen. This young girl is praying. Please save my dad or mom from heart attack. Don't wait until this, because at that time, nothing much can be done. This God will answer the prayer only when you have taken care beforehand. Now, should we not start early in the 20s and 30s? Should we wait till we suffer and succumb? Is it not cost effective and safe to take action now? What for are we waiting? Whose permission is needed? Who will do this? It will never be a priority for our rulers. They have several priorities for political parties. Prevention of heart disease is not their priority. We, the answerable one, should take the steps. Take a pledge now to screen everybody for cardiometabolic risk above 30 years. Initiate them into preventive action, persuade and persist. Now, this gentleman is happily playing with the grandchild. Grandparenthood is a boon. There is a place called love in this world. It is grandparenthood. Now, we should live to the age to enjoy the grandparenthood. Suppose somebody dies in 40s or 50s. Where can he be where is the grandchild? How can he enjoy this place of love? So always make sure that people live long enough to enjoy that beautiful grandparenthood. One has to live until that age, keep the health to enjoy it. Okay. So with this we are closing. Next session will be on the PCI. Not today, some other time we will talk more about the PCI. With this, the presentation on on the acute coronary syndromes is over. I'm going to share you the video as well as the PDF of this, and you all go through it, and not only going through that understanding, apply it in your clinical practice and give benefit to all those who are worthy of that benefit. Okay, so let us close this here, and all of you can leave.